Welcome, everyone, and thank you for joining us today for our webinar titled Measuring Tissue Perfusion and PO2 in Conscious Animals to Investigate Organ Failure. This is Haley McCaffrey from Inside Scientific, and I will be your host for today's event. Our session is sponsored by Synthica Instrumentation and will feature Professor Clive May and Dr. Yogesh Lankadeva from the Florey Institute of Neuroscience and Mental Health, presenting new groundbreaking research in models of acute kidney injury. Methods used to gather these insights are made possible using the latest in fiber optic sensing technology to obtain dissolved oxygen and microvascular blood perfusion at the tissue level.
Thanks for the introduction, Haley. In today's seminar, we're going to present a webinar presenting our research in which we measure tissue perfusion and PO2 in conscious animals to investigate organ failure. I'm Clive May at the Preclinical Critical Care Unit at the Florey Institute of Neuroscience, and I'm going to present this with Yogesh Lankadeva, who is the National Heart Foundation Future Leader Research Fellow. So the importance of measuring tissue perfusion and PO2. You will all know that the homeostatic control of tissue perfusion and oxygenation is essential for normal organ function. Now, there's increasing evidence from numerous groups that in many disease states there are heterogeneous changes in perfusion of organs, leading to areas of hypoxia and organ dysfunction. It's essential to monitor these changes if we're to determine the pathological mechanisms that cause tissue hypoxia and to develop therapies to prevent the declines in organ function. Now, the challenge we had in our studies was to measure tissue perfusion and oxygenation chronically during the course of the disease, and to do this in conscious animals to avoid the confounding effects of anesthesia. Our recent studies we have done have demonstrated very dramatically that anesthesia has very powerful effects on tissue perfusion and oxygenation in the kidney. And I'm sure this is true in other organs. And this is mainly due to changes in sympathetic activity. So I'll just present an outline of the webinar that we're going to give today. We're going to describe the equipment we use to measure tissue perfusion and PO2, and this is mainly in the kidney, although we will present some work on the brain. We'll also show how we measure bladder urinary PO2 and the reason for this. We'll then describe how we implant probes for chronic measurement of tissue PO2, and this is done in the kidney mainly. We'll then present some validation studies. These will include looking at the long-term stability and the effect of altering blood flow to the kidney by occluding the renal artery. We'll then move on to some important preclinical studies in which we use an ovine model of sepsis, in which we look at intra-renal perfusion and oxygenation. And then Yogesh will present some very exciting new data looking at the effects of resuscitation with noradrenaline and angiotensin II. And finally, we'll finish with a couple of slides just showing some recent data in which we've measured perfusion and PO2 in the brain. So first, the equipment we use the OxyLite and OxyFlow equipment from Oxidoptronics. And if you look at the bottom right-hand side of the slide, you can see a diagram of the tip of one of these combination probes. This has a dual fiber laser Doppler probe, which enables measurement of tissue perfusion, a fluorescent optode to allow measurement of tissue oxygen pastoral pressure using a fluorescence quenching technique, and a thermistor to measure temperature. We use their monitors, which the ones pictured enable measurement with two probes, so you can get two measurements of PO2 and two measurements of flow. And on the bottom left is their standard probe that comes with a Lua lock and the fiber optic probe protruding to that. That obviously was not a useful approach for doing chronic implantation for long-term measurements. So we asked them to make a different kind of probe, that consisted of just the outer sheath with 20 millimeters of the fiber optic protruding from that. And on the right, you can see this in more detail. And what we've done is we've made a PVC piece of sheeting with gauze for strengthening, and we actually glue that to the two probes, and this enables us to then stick that onto the tissue of interest, and they stay in there firmly. You can see that one of the probes is fitted with the sheet at a right angle to it, and the other at an acute angle. And in the next slide, you'll see the reason for that, and that is that we're implanting these probes into two different positions on the kidney. So in the left-hand panel, you can see that one of the probes goes deep into the kidney, into the medulla. The other is superficial and goes 2 to 3 millimeters deep into the renal cortex. And in the same operation, this is in operation in sheep, we put a flow probe on the renal artery and also a renal vein catheter for blood sampling. On the right panels, you can see in the top, there's a photograph of the medullary probe already implanted. So we first insert a 25 gauge needle, 20 millimeters into the kidney, remove that, and then slide the probe into the kidney. And the lower panel shows the kidney with both probes inserted. And we glue this blue sheeting onto the capsule of the kidney with super glue. This shows you a kidney removed after 10 days implantation, and you can see that the probes are securely fixed in place. And we find that really there is no movement at all. And as I'll show you later, we get very consistent results with these implanted probes. Importantly, we found there was little damage to the kidney, and this shows the renal cortex and medulla after 8 days implantation of fiber optic probes. The top two panels show H&E staining, and the bottom panels show Masson's trichrome sharp fibrosis. And we could see no visible hematoma around any of the probe tips. And around the probes, there was minimal observable damage and little fibrosis in either the cortex or the medulla. We also have been interested in measurement of bladder urinary PO2, and we'll explain the reasons for this later in the webinar. And for this, we use the Oxford Optronics large area sensor. And on the right-hand side, you can see that this is a different structure to the other probes. This is a more robust probe, and the tip of it is shielded in this metal casing. To measure urinary PO2 in the bladder, our animals have a bladder catheter inserted. The bladder catheter is then joined to a TUI Y adapter, and the probe is fed through this adapter all the way to the tip of the kidney. And in the bottom right, you can see a close-up of the tip of the bladder catheter, and you can see the probe tip just in the window of the bladder catheter. It's possible to tighten the TUI so that the urine does not leak out past the probe, and urine drains out through the tube attached to the three-way tap. So now move on to some of the experiments we've done. This is really a validation experiment. The top panel shows renal blood flow. The middle panel is tissue oxygenation, and the bottom one is tissue perfusion. And we measured oxygenation and perfusion in both the cortex, as shown by the dark circles, filled circles, and the medulla, as shown by the open squares. And these are recordings in conscious sheep, 2 to 3 days after implantation of the probes. And this is a recording over a 24-hour period. You can see that over the 24 hours, there was little change in renal blood flow. little change in cortex or medullary tissue O2 or perfusion. What was very interesting was that, in contrast to previous findings in the anesthetized animals where medullary PO2 was significantly less than cortical PO2, we found that in the conscious sheep that the resting levels of PO2 were similar in both areas of the kidney. And we think this really shows that in order to understand what's happening in the conscious animal, you need to do the experiments in conscious animals. And this is why it's important to have a technique where you can implant these probes chronically and measure these variables over long periods of time. Importantly, we also monitored these animals for a number of days, and the levels were maintained for 5 days of measurement, providing confidence that the chronically implanted probes provide stable readings over a number of days. We then examined the effects of a 20% and 50% reduction in renal blood flow on the cortical and medullary perfusion and PO2. And again, this was done in conscious sheep with implanted probes. So in the top right-hand panel, you can see the effect of occluding the renal artery using an implanted vascular occluder. So we occluded the renal artery, so we got a reduction in blood flow to the kidney, 20% and 50%. This caused small increases in blood pressure. And then if we examine the effects on cortical perfusion, you can see there was a graded perfusion depending on reduction in perfusion, depending on the degree of fall in renal blood flow. And this resulted in large decreases in cortical PO2. Similarly, there were drops in medullary perfusion and also medullary PO2. And these values came back to control values, and within, we only show you 15 minutes here, but within 30 minutes to an hour, values had come back to control levels. So we think that these reductions in renal blood flow producing graded decreases in cortical medullary tissue perfusion, and the fact that they came back to similar levels following this is again evidence of the reliability and reproducibility of these probes. So I'm now going to move on to the studies that we've been doing in an ovine model of sepsis. In this model, we induce sepsis by infusing live E. coli. This produces a model of sepsis that has a very similar phenotype to human sepsis. So it develops hypotension, an increase in cardiac output, tachycardia, and reduction in renal function. And the development of acute kidney injury is shown by the increase in plasma creatinine and reduction in GFR. So in this experiment, we had a 24-hour baseline period followed by a 24-hour infusion of E. coli, and then a 24-hour period of recovery. And you can see that during the infusion of E. coli, there's a substantial drop in blood pressure. There was, however, an increase in renal blood flow. So it was intriguing to see what the effects on the intra-renal oxygenation and perfusion were. So if we first look at the cortex, you can see that even though we had an increase in renal blood flow, there was little effect on cortical perfusion or in cortical PO2. But interestingly, there was a significant drop in medullary tissue perfusion and a really large drop in medullary tissue PO2 from a normal value of about 30 to close to 10 millimeters of mercury. So this is really quite a substantial drop, and we think that this is one of the causes of the acute kidney injury that develops in sepsis, and Yogesh will describe this in more detail. So we were interested in examining what effect vasopressors that are used for resuscitation in sepsis have on renal hypoxia, whether they improve it or worsen it. Now, noradrenaline is the main vasopressor that's used to restore blood pressure and maintain renal function in septic patients. We have done a number of studies that suggest that angiotensin II should also be used as a primary vasopressor in sepsis. One of our papers is shown on the right-hand side, and we've also recently published another in critical care medicine, and Yogesh will present these data. Interestingly, there's now been a number of clinical trials examining the effect of angiotensin, and the conclusion to this paper in New England Journal was that angiotensin II effectively increased blood pressure in patients with vasodilatory shock that did not respond to high doses of conventional vasopressors. But at the moment, the effects of resuscitation with noradrenaline or angiotensin II on intra-renal perfusion and oxygenation during septic AKI are unknown.
Now we will move on to the second half of our webinar to test the effects of commonly used vasopressors in intensive care on global and intra-renal perfusion and oxygenation in the kidney. So briefly, I will go through the surgical technique that Clive outlined earlier. Our animals commonly undergo two surgeries. During the first surgery, we exteriorize the carotid artery to form a carotid arterial loop to facilitate arterial cannulation to measure blood pressure and heart rate. 2 to 3 weeks following this surgery, we bring the animals back into the operating theater to perform a renal surgery that is shown on this slide. So as Clive suggested earlier, during this surgery, we implant a transit time flow probe around the renal artery to measure total kidney blood flow. We cannulate the renal vein for blood sample collection to later estimate renal oxygen delivery, consumption, and oxygen extraction ratio at the whole kidney level. And during the same surgery, we implant Oxford Optronics fiber optic probes into the renal cortex and the renal medulla. Importantly, these combination probes allows the simultaneous measurement of tissue perfusion and oxygenation and temperature in these two vascular regions in the kidney. The picture on your right is a picture of the surgery where we have implanted the medullary tissue oxygen probe, and we are about to implant the cortical tissue oxygen probe through a guiding needle. Before I move on to the experimental protocol, I will outline the importance of this study. As Clive suggested, noradrenaline is currently the recommended first choice vasopressor used clinically to restore blood pressure and kidney function in patients with sepsis and acute kidney injury, while angiotensin II is emerging as an effective rescue vasopressor for patients that are unresponsive to noradrenaline. However, the effects of such vasopressors on intrarenal tissue perfusion and oxygenation is currently unknown, and this was the aim of these studies. Now we move on to the experimental protocol, where following a 24-hour baseline measurement period, animals received a bolus and a continuous infusion of live E. coli for 32 hours continuously to induce hyperdynamic sepsis. At the 24th hour of sepsis, animals were randomized to receive either noradrenaline, angiotensin II, or saline vehicle for 6 hours continuously. The dose of noradrenaline and angiotensin II given was titrated to return blood pressure back to pre-morbid levels. Following this 6-hour infusion, animals were cardiovascular and renal variables were monitored over a 2-hour recovery period. During this protocol, we collected arterial, renal, venous, and urine samples at predefined time intervals to measure blood gases and creatinine and sodium. Moving on to results, we are looking at mean arterial pressure, heart rate, renal blood flow, and renal vascular conductance at baseline. And then at 24 hours, and then following 6 hours of treatment with either noradrenaline, angiotensin II, or saline. We are first looking at the vehicle treatment group that's going to be shown by the open circle. We see that similar to our previous findings, by 24 hours, animals have developed established hypotension. They are tachycardic, where their heart rate has increased, and they have increases in total kidney blood flow and increases in renovascular conductance, or in other words, a large reduction in renovascular resistance, which suggests that the renal circulation does in fact participate in the systemic peripheral vasodilatation in hyperdynamic sepsis. Now moving on to resuscitation with noradrenaline and angiotensin. Noradrenaline shown in the red circles, angiotensin in the blue circles. We see that both these vasopressors were effective at restoring blood pressure back to baseline levels during the 6-hour infusion. They had no significant effects on heart rate or total kidney blood flow, but they induced renal vasoconstriction, at least at the whole kidney level. Looking at kidney function, we're looking at urine flow, plasma creatinine, and glomerular filtration rate. We see that by 24 hours of sepsis, our animals have developed acute kidney injury, characterized by oliguria, increases in plasma creatinine, and a large reduction in glomerular filtration rate as estimated by creatinine clearance. Moving on to resuscitation, we see that both noradrenaline and angiotensin II significantly increased urine flow, brought about reductions in plasma creatinine, and brought about a transient increase in glomerular filtration rate. So at least looking at the whole kidney level, both these vasopressors appear to be having desirable clinical effects. But what is happening within the kidney? This is where the really interesting results come. So we're looking at cortical tissue perfusion and oxygenation. We see that with an increase in global kidney blood flow, cortical tissue perfusion tended to increase, and cortical tissue oxygenation also had a tendency to increase. In contrast, similar to our previous findings, we see that there are significant selective reductions in renal medullary tissue perfusion and oxygenation, which was sustained up until 32 hours of sepsis. If we look at the temporal profile of the changes in medullary tissue oxygen levels with the development of acute kidney injury over 24 hours of sepsis, we see that the reductions in medullary tissue oxygen levels took place within the first hour of the infection, which was several hours prior to the development of acute kidney injury. This adds further strength to our speculation that medullary tissue hypoxia may indeed play a critical role in the initiation and progression of acute kidney injury. Now, the next important question is, what is the effects of clinical vasopressors on medullary tissue oxygenation? We see that resuscitation with noradrenaline, which is the primary vasopressor in the clinic, had no significant effects on cortical tissue perfusion or oxygenation. However, noradrenaline resulted in a further exacerbation in medullary tissue ischemia and hypoxia. Concerningly, this suggests that the first choice vasopressor they use in ICUs to resuscitate patients with septic acute kidney injury may have deleterious effects to worsen kidney injury in the longer term. In contrast, when we look at resuscitation with angiotensin II, we see that angiotensin II had no significant effects on cortical tissue perfusion and oxygenation, and importantly, it had no significant effects on medullary tissue perfusion and oxygenation, which would suggest that, at least in the setting of septic acute kidney injury, angiotensin II may indeed be a safer alternative to noradrenaline as a primary vasopressor. Now, going into our knowledge about sepsis and acute kidney injury, sepsis is the leading cause of acute kidney injury, where 50% of all patients with sepsis develop acute kidney injury, and emerging evidence suggests that this is primarily driven by renal tubular injury, which then progresses to a functional loss in the kidney, causing these kidneys to fail. On our major limitation in the conventional biomarkers that's used to diagnose patients with acute kidney injury is that you can see that serum creatinine, is a marker of kidney dysfunction, which occurs at a very late stage of kidney injury. Whereas emerging biomarkers such as urinary NGAL or plasma cystatin C are markers of renal tubular injury. It's very obvious that these are all diagnostic tests that are used to detect kidney injury that has already happened. Now that we know that medullary hypoxia occurs very early in infection, developing a biomarker to detect reductions in medullary oxygenation would in fact be a marker of risk rather than injury, which would allow early preventative strategies to be employed. So to do this, we looked at the renal architecture, vascular architecture, and what we're seeing in this diagram is a very nice diagram of the inner base of a rat medulla, where they have labeled the descending vasa recta, which is the blood supply to the renal medullary region, in green, and the ascending vasa recta in red, and the collecting ducts in blue. This is where the urine ultimately gets collected before it gets sent down through the ureter to the bladder. And what we see is that the ascending vasa recta is positioned very close and symmetrically around the collecting ducts in the kidney. Because of this intimate association, we hypothesized that renal medullary tissue oxygenation would equilibrate with urinary oxygenation during development of septic acute kidney injury. To test this, we have got Oxford Optronics to develop a large area oxygen sensor. As Clive highlighted earlier in his talk, we inserted this large area oxygen sensor through a standard bladder catheter to sit at the tip of the bladder catheter in the bladder. And this allows us to simultaneously measure bladder urinary oxygen tension with intra-renal tissue oxygen tension in the kidney, both in the healthy state and during development of acute kidney injury, and then following them through to vasopressor therapy. What we see is that during the development of acute kidney injury, excitingly, the very early reductions in medullary tissue oxygenation, now shown in green, were very closely reflected by reductions in urinary oxygen tension, shown in purple. And when we looked at the correlation between these two variables during 24 hours of sepsis, we see that there was a very significant and positive correlation. We took this another step further, where we compared this new biomarker with conventional clinical biomarkers, which is serum creatinine and urinary NGAL during development of septic acute kidney injury over 24 hours. And what we see here is that serum creatinine took up to 24 hours for significant difference to be detected, whereas the emerging biomarker, urinary NGAL, increases in this biomarker was only detected at 8 hours of sepsis. In comparison, we see that the reductions in medullary tissue oxygenation occurred within the first hour of sepsis, and this was again very nicely reflected and detected by decreases in urinary oxygen tension. So we can, in conclusion, we can detect urinary hypoxia at least 8 hours earlier than conventional biomarkers. We took this another step further. Now we know that it detects hypoxia at a very early stage. The next important question is, can we use urinary oxygenation as a reliable technique to estimate medullary tissue oxygenation during vasopressor therapy? And the answer to this question was yes, where the further reductions in medullary tissue oxygenation we see with noradrenaline was again very nicely detected by further reductions in urinary oxygenation. And the preservation in medullary tissue oxygenation with angiotensin II was again nicely reflected by preserved urinary oxygenation with angiotensin II treatment. And during all three treatments, we again see a significant and positive correlation between bladder urinary oxygenation and medullary tissue oxygenation. We have now translated our findings to the clinic at Austin Health in Melbourne, where we are testing bladder urinary oxygenation in patients with sepsis and acute kidney injury. And excitingly, in the 3 patients that I have analyzed here, we see that the level of urinary hypoxia in human septic AKI is very similar to the level of urinary hypoxia we see in bovine septic AKI. And even more excitingly, following infusion or resuscitation with noradrenaline, these patients also show a further reduction in urinary oxygen levels, which we now know reflects reductions in medullary tissue oxygen levels. This brings me to my last slide. We can see that medullary hypoxia occur very early in septic acute kidney injury, and we suggest that measurement of bladder urinary oxygenation may indeed have the potential to be a non-invasive, real-time biomarker to aid in the early diagnosis of acute kidney injury in patients. We also suggest that bladder urinary oxygen tension could also be a reliable technique to obtain accurate measures of medullary tissue oxygenation during vasopressor therapy in the intensive care unit. So this brings me to the end of my presentation. I will now hand over to Clive to finish off this webinar.
Thank you, Yogesh. So we'll now jump from the kidney to the brain, where we've recently been doing some experiments where we've used the oxidochronic probes in experiments to look at brain perfusion following a cardiac arrest. So briefly, to implant the probes, we have done 2 small craniotomies over both the left and right cerebral cortex, and we insert the probes about 15 millimeters into the brain itself, and we fix the outer sheath of the probe to the skull with dental cement. We found that the readings immediately we implanted the probes were not all that stable, but if we came back and measured 2 days later, we found we got good stable readings. So the experiment we did was to look at the effect of cardiac arrest followed by open chest cardiac massage. And we were looking at the effects on mean arterial pressure, carotid blood flow, and tissue perfusion and oxygenation measured by the probes in the left and right hemispheres. What you can see in the top panel is that as soon as we induce cardiac arrest, as expected, there's a big drop in mean arterial pressure and carotid blood flow drops to 0. This is followed by, well, accompanied by falls in tissue PO2 to 0 and also tissue perfusion. So it's comforting to see that these flows and oxygenation mirror the changes in carotid blood flow. And during cardiac massage, we could get some restoration of mean arterial pressure, a small increase in carotid blood flow, and this was accompanied by similar changes in perfusion in both sides of the brain and really quite small increases in tissue PO2. So we think that these data really give some validity to the measurements of brain perfusion and PO2 using these probes in the brain. And we think that this is indicated by the large decreases post-cardiac arrest and the improvement with cardiac massage in both tissue PO2 and perfusion, the similar changes in these variables in the 2 probes in the different hemispheres of the brain, the similar changes in tissue perfusion and carotid blood flow suggest that we're getting good measurements with the laser Doppler probes. And we've also looked at the level of perfusion during cardiac arrest and cardiac massage. And we've also measured this by perfusion-weighted imaging in an MRI scanner. And using that technique, we see very similar changes in perfusion. So using a completely independent technique, we're getting similar data, which again gives us confidence that the changes we're seeing measured with these probes are real. So I'll now just move on to a summary of what I've presented. This is really the equipment and the techniques So we've developed a method to chronically implant fiber optic probes in the kidney for measurement of tissue perfusion, PO2 and temperature. These probes cause minimal tissue damage, they remain fixed in place, and they provide stable measurements for at least 10 days. We've shown you that it's also possible to measure bladder urinary PO2 using a probe inserted into the tip of the bladder catheter. And these techniques enable long-term monitoring of microvascular changes and alterations in tissue oxygenation during the development of the disease and also the effects of treatments. Second summary is the preclinical work which Yogesh presented. And we've shown that in sepsis there is redistribution of intra-renal blood flow as indicated by reduced medullary perfusion and development of hypoxia, while cortical perfusion and oxygenation is preserved. Changes in bladder urinary PO2 closely follow changes in medullary PO2, suggesting that urinary PO2 may be a useful, non-invasive, real-time biomarker to predict the development of AKI. We've shown you that noradrenaline, the primary vasoconstrictor used to maintain arterial pressure in septic patients, enhanced the level of medullary hypoxia. It's currently unknown if this hypoxia enhances the progression of AKI, but this is an obvious area of further experiment. Angiotensin II restored arterial pressure in sepsis without causing further hypoxia in the renal medulla or cortex. And we think that angiotensin II should be considered as a primary vasopressor drug in septic AKI. So that's the end of the webinar. Thank you all for your attention. We'll now go to a brief Q&A section.
Thank you both so much for sharing your research today. Just quickly before we continue on with our Q&A, I would like to introduce Michael Rao, who's joining us from Oxford Optronics. Michael, thank you so much for being with us.
My pleasure, my pleasure. Happy to join you.
Great. Okay, so we've had a number of questions come in ahead of time and during today's webinar, so let's get started. Our first question today will be directed to Clive and Yogesh. So why do the perfusion measurements not always correlate with the total renal blood flow measurements?
Yeah, that's an interesting point. This is because we're using two totally different methods. The transit time is measuring total blood flow across the whole blood vessel, the whole renal artery going into the kidney, whereas the laser Doppler is just measuring microvascular blood cell perfusion in a small area of the tissue in different zones of the kidney in the medulla and cortex. We wouldn't therefore expect these to be identical, and I think that the data we've got indicates certainly that the perfusion measurements are giving us a good index of what is actually happening in these different zones of the kidney.
And I'd like to add on to Clive's answer and say it's also important to note that the measurements we get with laser Doppler is a measure of flux, and it doesn't take into account the number of perfused capillaries.
Okay. Our next question, coming back to you guys, what is the mechanism causing decreased perfusion and hypoxia selectively in the renal medulla during sepsis?
This is a really important question, and this needs to be investigated further in our future studies. But we do hypothesize that a number of mechanisms might be involved in this redistribution of intra-renal blood flow. And some of the primary mechanisms we think might contribute to this is the expression of inflammatory cytokines in localized areas within the kidney, and also deficits in nitric oxide mediated vasodilatation within the renal cortex and the renal medulla. Certainly in our previous studies, we have used this model to do gene expression for various isoforms of nitric oxide synthesis, such as endothelial-derived nitric oxide synthase, which is a primary contributor to the nitric oxide mediated vasodilatation in the medulla. And we have reported that gene expression for endothelial nitric oxide synthase is actually downregulated within the renal medulla, whereas endothelial nitric oxide is upregulated within the renal cortex. This might be a mechanism, but as I said before, this needs to be investigated further.
Okay, thank you. Michael, this next question is directed to you. Is it possible to use this method, or can it be altered to measure cerebral perfusion during resuscitation?
The short answer to that is absolutely yes. Our monitors and sensors have been used quite extensively in a variety of animal models to make cerebral measurements in a variety of situations. Obviously, there's the question of access, and sensors need to be placed via craniotomy. But absolutely yes, and I believe that Professor May and Dr. Lankadeva, both you presented some of your slides were describing, were they not, the use of our sensors in the brain. Is that right?
Yeah, we've been using it in a sheep model of myocardial infarction, in which we've been monitoring cerebral perfusion and oxygenation. I think, as we mentioned in the webinar, that we find if we put the probes in very acutely, they don't give what we think are correct results, but certainly once we've had them implanted for a day or two, they give excellent readings, which seem to correspond very much with other measures we have.
Right. That's very interesting because we've also in other situations observed, in other large animal situations observed a requirement for sensors to be in place for a period of time of 1 or 2 days, very much in line with what you observed, and thereafter things seem to work very well and seem to generate believable and responsive data. In small animal models, and I guess I'm primarily talking about rodents, it seems to be a very straightforward application, and we don't typically see a requirement for a lengthy equilibration time at all. And generally speaking, in rodents, often using stereotactic apparatus to maintain the sensor. It is one of the most reliable applications we see for our monitors and sensors.
Great. So actually, I might just jump ahead a little bit here and then ask this question to you, Michael, as well. Can this be used for measuring perfusion in other organs, such as the liver or heart? And then I know we were talking just a bit about, you had mentioned a couple different animal models. Is there any animal model where this procedure wouldn't apply?
I can't really say. I don't believe there's really any animal model that we exclude for any particular reason. In terms of other organs and tissues, yep, absolutely. I mean, each type of organ or each tissue type comes with its own kind of set of challenges or advantages and difficulties. For instance, liver can be challenging for whatever reason, partly to do with its kind of physical nature, its physical properties. So PO2 readings, invasive oxygen readings can be a bit challenging. Perfusion readings can be made non-invasively via the surface of the liver quite reliably. Things like moving tissues, the heart is challenging, obviously, by virtue of the fact that it's a moving tissue, but we've been successful in obtaining reliable oxygen readings from that tissue. In that case, however, perfusion readings using our laser Doppler monitors is challenging simply by virtue of the fact that the tissue is moving, and therefore it's very difficult to observe a baseline away from movement artifact. But yeah, bottom line, the monitors and these sensors can be used in a whole whole variety of tissue types.
Perfect. Clive and Yogesh, how good of a measure of medullary PO2 is urinary PO2, and what factors influence this relationship?
I think it's important to understand that the value of bladder urinary PO2 we get is not an absolute value of medullary tissue PO2, but what we are rather suggesting is that the pattern of change between these two variables are quite similar, not only in the healthy state, but also during development of acute kidney injury and also following resuscitation with commonly used clinical vasopressors. And what we have found in our experiments is that the signal of medullary signal of bladder urinary PO2 to detect medullary PO2 is greatly enhanced under diuretic conditions where there is a high urine flow from the renal pelvis to the bladder. So certainly under conditions such as volume resuscitation, or in the cases where they're given diuretics such as furosemide, we see the signal to be quite enhanced between these two measures.
Yeah, so I think it's important to emphasize that you have to have a good urine flow for this to this correlation to be close. And if urine flow drops below between lower than 1 ml a minute, then the correlation is less close.
Okay, great. Michael, how are the long-term sensors calibrated to ensure continued accurate measurements of tissue oxygenation?
Right, that's a good question. We calibrate each sensor individually against a range of 6 nitrogen-oxygen mixtures between 0 and, if I remember right, 21% oxygen. And that data is converted into a calibration curve for that individual sensor and is stored inside a little microchip in the connector for that sensor, which is read by the monitor once the sensor is connected. The beauty of, so in other words, the bottom line being that sensors are supplied pre-calibrated, and there's no calibration procedures required or that the end user needs to do. By virtue of the fact that we use a method of measuring fluorescence lifetime rather than fluorescence intensity, we are able to provide that pre-calibration on the basis that it won't change or evolve or decay during use. So we see very little drift over the course of the specified lifetime of sensors.
Okay. And then Clive and Yogesh, maybe Michael, you might be able to join on this question as well. I know Clive and Yogesh, you mentioned that you've reused the probes in the past, but is there an anticipated lifespan on them, or how long can you reuse them? Is it a one-time thing, or is it can you reuse them many times?
First, I'll just say that we've had probes implanted for 3 weeks, I think is the maximum, and we've been able to continuously obtain measurements over that period of time. I think the other thing to say is that over that period of time, the measurements are stable, again suggesting that the calibration is stable and that we're getting, believable and useful measurements. We take our probes out, usually after a week is the length of our normal experiment, and generally we can reuse them again. Occasionally we can reuse them a third time, but probably in general I'd say we use them twice. So we use them for 2 one-week periods.
That's interesting. I guess Mike, I was going to ask, what sort of, I guess you're not reading continuously during those 1, 2, or up to 3 weeks. Presumably you kind of connect the sensor from time to time to make sort of time point measurements. Is that readings? Is that right?
We do continuous measurements for about 56 hours in the conscious animal. But the important thing here to understand is that the monitors do allow you to change the acquisition time.
Yeah.
So if you were acquiring one every second, then of course the probes won't last as long. But if you were to acquire data 1 in every minute or 1 in every 5 minutes, it does allow you to do these long-term measurements, which is quite useful with these long-term studies.
Right, that's interesting. Yeah, I guess I was kind of getting at whether you were reducing the sampling rate, and that is a key feature on our oxygen monitors, is that the user can dial in the kind of sampling rate to suit the experiment, given that there is a sort of an accumulated lifetime limitation on the oxygen sensing part of our monitors.
Excellent.
Yeah, and also I'll just add on towards the end that once we do take these probes out, it is possible to do a quick check if the calibrations are still in. What we commonly do is we test it in room air, and then we bubble it with in a solution with carbon dioxide to see the upper and the lower limits, and then that kind of gives us confidence that these probes are still detecting levels of changing oxygen levels, so we can reuse them if we had to.
Perfect. Yeah, that makes a lot of sense. I mean, we see basically pretty much a black and white situation with sensors. They either work, and doing that test in air and at zero oxygen is the perfect way of checking whether they do or they don't. It's pretty much black and white. We always find.
Yeah.
Great. Well, that was fantastic. Thank you all so much for your contributions to this very engaging Q&A.